Welcome, everyone. Consider me your attending physician for the day, and let's just jump right into this high-yield explainer. We're focusing strictly on the advanced clinical overview of metabolic, pain relief, and anti-inflammatory pharmacology. This explainer is specifically designed to cut right through the noise. We are targeting exactly what you need to master: the granular molecular mechanisms, the critical diagnostic parameters, and of course those absolute black box safety warnings. Okay, here's our game plan for today. We'll be looking at 1. Advanced anti-diabetic pharmacology. 2. Insulin signaling and formulations. 3. Paracetamol biochemistry and toxicity. 4. NSAID and aspirin mechanisms. 5. Opioid receptors and disinhibition. And finally, 6. Opioid kinetics and overdose. We're basically mentally organizing our pharmacological buckets, moving sequentially from chronic metabolic control right through peripheral pain modulation and wrapping up with complex central neurotoxicology. Starting with Section 1, Advanced Anti-Diabetic Pharmacology, the oral and injectable landscape. You know, glycemic management is no longer just about lowering sugar. It is a high-stakes arena of comprehensive organ protection. Let's strictly signpost the molecular targets of our oral antidiabetics. First up, metformin. It activates AMPK to reduce hepatic glucose production, but, and this is a big but, it carries a very dangerous risk of lactic acidosis in severe renal failure. Next, we have the sulfonylureas. These directly stimulate insulin release by closing ATP-sensitive potassium channels in the pancreatic beta cells. It's a mechanism that, unfortunately, drives both hypoglycemia and weight gain. Finally, are DPP-4 inhibitors, which prolong endogenous incretin action. Notice the absolute standout here. Linagliptin is the premier option in this class because, unlike the others, it requires zero renal dosage adjustment, a total game-changer for renal patients. Now, what's truly fascinating is the massive paradigm shift brought on by SGLT2 inhibitors, or gliflozins, like empagliflozin. They act right in the proximal renal tubule to block glucose and sodium reabsorption. The resulting glucosuria and natriuresis provide immense cardiorenal mortality benefits. We're talking drastic reductions in hospitalizations, not just for diabetics, but even in non-diabetic patients with heart failure with reduced ejection fraction, or HFrEF. You do, however, have to watch out for euglycemic DKA. On the other side, we have GLP-1 receptor agonists like semaglutide. They delay gastric emptying for potent weight loss, but they come with a strict black box contraindication for patients with any history of medullary thyroid carcinoma. Moving on to Section 2, Insulin signaling and formulations, peptide pharmacokinetics. Getting strictly into the mechanics of exogenous insulin delivery, we really have to understand its fundamental structural limitations.
Understanding these structural limitations is exactly what builds our clinical protocols. Because insulin is a peptide hormone, its very structure mandates a parenteral route, usually subcutaneous. If you were to give it orally, it would just get completely chewed up and degraded by GI enzymes. Once it actually makes it into the blood, it docks strictly to tyrosine kinase receptors to facilitate glucose uptake into muscle and fat. Clinically, we leverage its pharmacokinetics by splitting the formulations. We use ultra-rapid types to cover meals and long-acting basal types to mimic the steady background release of a healthy pancreas.
All right, Section 3, Paracetamol biochemistry and toxicity, central modulation and hepatotoxicity. Let's shift gears to analgesia, adopting a rigid academic tone to dissect a drug you literally see every single day. The exact central mechanism of paracetamol has been highly debated, so let's clear the air once and for all.
I want you to listen closely to this exact scientific script. While a splice variant of COX-1, historically termed COX-3, was observed in animal models, modern molecular research has confirmed that a functional, distinct COX-3 enzyme does not exist in humans. This definitively, word for word, debunks the myth of the human COX-3 enzyme. So you might be wondering, how does it actually work?
Well, the real mechanisms are incredibly cool. Paracetamol exerts a weak, state-dependent inhibition of human COX-2 centrally to reduce pronociceptive PGE2. But more fascinatingly, it shunts arachidonic acid into the 12-lipoxygenase pathway. This produces 12-HET, a compound that acts as a central potassium channel blocker to reduce neuronal excitability. Furthermore, paracetamol actually converts in the brain into AM404, which blocks reuptake transporters to raise central anandamide levels. This leads to CB1-mediated antipyrexis. It's just a remarkably complex indirect endocannabinoid modulator.
The crucial takeaway here is understanding the exact step-by-step molecular failure during an overdose. Normally, about 8 to 10% of paracetamol is metabolized by CYP450 into a highly reactive toxic compound known as NAPQ. Thankfully, your liver detoxifies this using glutathione. But in a massive overdose, those glutathione stores become entirely depleted. The unneutralized NAPQ then binds directly to hepatitis, causing fatal necrosis. This is why the life-saving resuscitation protocol relies on N-acetylcysteine, or NAC. It acts as a precursor to rapidly restore those absolute vital glutathione stores.
Section 4, NSAID and aspirin mechanisms, peripheral analgesia and arterial prevention. Proceeding over to classical NSAIDs, we're going to contrast their peripheral anti-inflammatory mechanisms right against paracetamol's strictly central effects.
We really need to drill down on the functional differences between the cyclooxygenase isoforms here. COX-1 is constitutive. It's practically always working in the background to protect your gastric mucosa and maintain renal blood flow. COX-2, on the other hand, is inducible, upregulating specifically during inflammation. Now, while selective COX-2 inhibitors like celecoxib do a great job protecting the stomach, they carry a highly dangerous cardiovascular risk profile. Why? Because they selectively suppress vascular prostacyclin while leaving COX-1-mediated thromboxane completely untouched. This creates a highly pro-thrombotic environment.
Then we have aspirin. It's a completely unique NSAID because it irreversibly acetylates platelet COX-1. This effect lasts for the entire lifespan of that specific platelet, making aspirin the absolute bedrock of secondary arterial prevention after an MI or an ischemic stroke. But I must hammer home this strict black box contraindication. Aspirin is absolutely avoided in pediatric viral illnesses due to the risk of Rey syndrome. It's a catastrophic condition triggering acute brain dysfunction and fatty liver failure. Never forget that one.
Section 5, Opioid Receptors and Disinhibition. Central Nervous System Neuropharmacology. Take a breath, because we are transitioning into the most complex portion of today's explainer, the central neuropharmacology of opioids.
We have to understand this molecular receptor binding at a highly granular level. Opioids are full agonists at the mu receptor, which is coupled to inhibitory G/O proteins. When the opioid binds, the G protein splits. The alpha subunit goes off and inhibits adenylyl cyclase, drastically dropping intracellular CAMP. Simultaneously, the beta-gamma complex does two distinct physical things. Presynaptically, it blocks calcium channels to halt the release of pain transmitters like substance P. Postsynaptically, it opens potassium channels to hyperpolarize the nociceptive neuron. Okay, so let's dive into this brilliant little paradox. How do inhibitory drugs actually cause excitation of the body's natural pain filters? Well, it happens right in the periaqueductal gray, or PAG. Normally, local GABAergic interneurons are constantly releasing GABA to keep your descending pain filters turned off. Opioids bind to and inhibit these GABAergic interneurons, essentially turning off the off switch. This decreases GABA release, which then disinhibits the glutamatergic projection neurons, allowing them to finally fire those powerful descending anti-nociceptive signals right down to the spinal cord.
Section 6. Opioid kinetics and overdose, advanced toxicology and resuscitation protocols. We are now entering the final phase of the explainer, demanding your absolute attention to clinical kinetics and lethal toxicology. Notice the very rigid pharmacokinetic separation here. Codeine is entirely reliant on polymorphic CYPD2D6 for bioactivation, meaning ultra-rapid metabolizers can face sudden, unexpected toxicity. Morphine undergoes hepatic phase 2 conjugation into M3G, which is neurotoxic, and M6G, which is a potent respiratory depressant. Because both of these active metabolites are cleared renally, morphine becomes absolutely lethal in kidney impairment. Fentanyl is our highly lipophilic synthetic choice, making it the standard for rapid breakthrough cancer pain. Then there's methadone, with a massive 72-hour half-life and unique multi-target mechanics like NMDA antagonism, making it perfect for neuropathic pain, but very risky for accumulation. Finally, buprenorphine. This drug utilizes biased signaling. It activates G proteins for analgesia, but specifically avoids recruiting beta-arrestin. This avoidance of beta-arrestin creates a distinct, life-saving physiological ceiling for respiratory depression.
Now, when things go wrong, we see the classical clinical triad: coma, meiosis, or pinpoint pupils, and life-threatening respiratory depression. Resuscitation requires reversing this with the competitive antagonist naloxone. But heed this clinical instruction closely. The primary therapeutic endpoint is the immediate restoration of regular ventilation, not full consciousness. Stop pushing once they are breathing. Furthermore, naloxone has a dangerously short 30 to 90-minute half-life. If it wears off before the opioid does, your patient will plunge right back into recurrent respiratory toxicity. Continuous tracking is absolutely mandatory here.
Well, we've covered immense ground today, from the incredible renal protections of glyphosines to the complex bias signaling of modern analgesics. So I want to leave you with this provocative thought to ponder. As we continue to master these molecular targets, from AMPK all the way to beta-arrestin, how will the next generation of pharmacology balance profound therapeutic efficacy with the absolute necessity of physiological safety ceilings? Think on that as you review the material. Until next time, keep learning.